I will invite Dr. Madhu Gupta to tell us about the objectives of the CME.
Thank you, Dr. Neena. So I am Professor Madhu Gupta in Department of Community Medicine, PGI Chandigarh. First of all, I would like to welcome all the participants, and I would like to welcome Dr. Alpesh Gandhi, who is the president of FOXY, and we are really privileged to have him here in this CME. And I would also like to welcome Dr. Pratima Mittal, and she's Professor Obs and Gynae from BMMC and Safdarjung Hospital, New Delhi. Dr. Rajal Thakur, who's a professor at NHL Municipal Medical College, SCL Hospital, Ahmedabad, and also President Ahmedabad Obs and Gynae Society. And also Dr. Ritu Joshi, she's a consultant at Fortis Hospital and also Vice President FOXY in 2014. And Dr. Shobha N. Guri, she's a chairperson, Family Welfare Committee. So from FOXY, and without their participation, this CME would not have been possible. And also, I would like to welcome UNFPA officials, Dr. Kirti Iyengar, who's a National Program Officer in UNFPA New Delhi, and Dr. Bimla Upadhyay, who's a consultant in UNFPA New Delhi. So thank you so much for being part of this CME. So coming to the objective, so briefly introduction, as we all know that reproductive health and sexual health, they go hand in hand. So these, I really like this floral diagram by WHO, which is a framework for operationalizing sexual health and its linkages to reproductive health. So as you can see that fertility care is part of reproductive health, and these yellow ones are related to reproductive health issues, and blue petals are related to sexual health issues, and they are interwoven. So these include fertility care, prevention and control of HIV and other sexually transmissible infections, then safe abortion care, then sexual function and psychosocial counseling, antenatal and intrapartum and postnatal care, which is reproductive health issue, and but comprehensive education and information is sexual health issues, and contraception and counseling and provision is again reproductive health issues, and related is gender-based violence prevention and support care, which is sexual health issues. So all these basically they have a founding guiding principles, including holistic approach to sexual health, linked nature of sexual health and reproductive health, respect, protection and fulfillment of human rights, multi-level influences on sexual health, diversity of needs across life course and populations, and evidence-based, respectful and positive approach. So with this background in mind, the objectives of this CME has been kept to provide information on standards of care in youth-friendly health services, including counseling services and clinical aspects of sexual and reproductive health problems especially among youth. So, and also we will be providing information and evidence-based information on self-care interventions for sexual and reproductive health, and integration of sexual and reproductive health and HIV and RTI services. I hope you will enjoy this academic feast by these three organizations. Thank you so much.
Sorry, I was muted. Thank you, Dr. Madhu. Now I'd like to invite Dr. Shobha, who is the chairperson, Family Welfare Committee and a renowned gynecologist. And she is working for Manipal Medical College. So Dr. Shobha, please, I would like to invite you to give us the inaugural address. Thank you.
I must place on record now immense gratitude and thanks for UNFPA and PGI-MER, all the faculty, Kirti, Neena, Madhu, everyone. I think this was a necessary exercise to reinforce our service provision and the passion that we have for women's healthcare This was very necessary that we all come together on a common platform. And thank you very much for making it happen. I must thank Dr. Alpesh Gandhi, Dr. Jaideep, and Dr. Atul for having concurred on this session, for both the sessions actually, and my peers in Foxy, my seniors, Dr. Pratima, and my friend Rajal, and all others who have agreed to join us to deliberate on these matters. I think so far, what you beautifully presented, Nina, so far, the chain of integration which WHO is propagating. In fact, the key word today becomes integration. And SRH services will be best served for our women if we can integrate it with our ongoing strong antenatal programs, our postpartum care, our post-abortion services, our care for adolescents, and our, in general, women who seek care for perimenopausal as well, menopausal services as well. But a very important part is addressing the youth, because there is very little direction for the crores of population of youth which are there today in India. We all know that almost 25 to 30% of the 138 and SRH services delivery to them is a challenge so unsurmountable, especially in the times of pandemic. So, as I said in the very beginning, such a commitment. Sorry, please begin the program now. I have finished.
Thank you, ma'am, for enlightening us with your views on sexual and reproductive health. And now I'd like to invite Dr. Kirti Iyengar, who's the National Program Officer for UNFPA, to express her views on this. Dr. Kirti, welcome, Dr. Kirti.
Hi, folks. How are you all?
Hi, Ritu.
Yeah, Dr.
Hi,
Ritu,
welcome.
Hi.
Welcome.
Hi, Dr. Shobha. You've joined?
Yes, I'm here.
Oh, lovely.
And
lovely.
Yes. And welcome,
Kirti
Dr.
has
Ritu.
yet to join?
No, Kirti is right there. And she's
Oh,
about
wow.
to
Hi,
speak.
Kirti.
Hi, Dr. Ritu.
How are you?
I'm fine, Dr. Ritu, and glad to have you. And we have just begun the CME, so I will just respond
continue,
to
please.
Dr. Nina's. Yeah. So thanks everyone for joining the CME. And as you know, COVID has been some once in a lifetime event, and it has really struck everyone, and especially for women and girls, as well as for men, it has really affected their access to sexual and reproductive health services. In terms of our providing, on the behalf of providers, it has become difficult because, as you know, many of the doctors and nurses were deputed in COVID duties, and many themselves fell sick, or they had these kinds of necessary rest periods, because of which the service delivery got affected. Further, the supplies of the medicines and drugs and equipment and various other things got affected. And of course, the third reason was that many of them were scared of contracting COVID, and they did not want to have much contact with the patients, and that also affected the delivery of services. On the other hand, people who wanted to seek the services, they got badly affected because of the travel restrictions. Although in a way now there are no travel restrictions, but people who have to use public transport, which is like 60 to 70% of India's population, who do not have a vehicle of their own, for them it becomes difficult, especially for women. Men still have a two-wheeler on which they can go to seek the services. For women, and especially girls, it became far more difficult. Women and girls don't even have the permission to go. Earlier, women have a reason either for the purpose of the job, or especially for the young people, for the purpose of attending the college or the high school. They were able to get out of the house, and if they had to a need to seek services, they could go. But with COVID, that also became difficult. And therefore, it has been estimated that there will be much, like a very large numbers of women and men who will not be able to seek contraceptive services, and women who will not be able to seek maternal care or abortion services. And there are estimates which have shown that in India alone, there could be more than 25 lakhs of unintended pregnancies, which are additional to what used to occur before. There could be up to 8 lakhs of additional unsafe abortions, and there could be about 7 to 8,000 of additional maternal deaths. So we have to really see as to how we do change our way of providing the services. The way we have been providing pre-COVID, do we need to make any changes? And in that context, this CME is very important, where we are going to discuss some very important issues like the self-care services and how to improve the access of services to young people to overcome these challenges. And also what we can do to integrate the services, because integrating the services will mean that for the provider also, instead of calling the patient twice, they have to call the patient once. And also for the patient to, rather than to go to two facilities on 2 different days, it becomes possible to just go once and reduce their travel and exposure. So now I would like to thank everyone for their efforts to make this CME happen. I would like to thank the PGI team who has been working day and night in the last several days to organize this thing. And I would like to thank FOTC for, coming forward with the suggestion. And then it was really very useful to get so many FOTC members, starting with Dr. Shobha, Dr. Alpesh, and Dr. Ritu, Dr. Pratima, and all the others who have joined. I would like to thank all of you for your active participation. And we really hope that we are able to brainstorm and have some very good suggestions for taking forward the SRH services in India, so that women do not suffer the adverse consequences. Thank you.
Thank you, Dr. Kirti. I think gender bias and domestic violence and reproductive health issues have really become worse during this COVID-19 pandemic. They were always there, but now they have become worse during this pandemic. And this CME was the need of the hour. So I think we can have a brainstorming session at the end and see what we can do about it. So now I'd like to invite Dr. Ritu Joshi, who is consultant Fortis Hospital, Jaipur, and also a former vice president of FOXI 2014. She has contributed various chapters in books of obstetrics and gynecology and is an editor for many books on contraception. So she is going to give us a talk on self-care intervention for sexual and reproductive health, clinical aspects and current perspectives in emergency contraception. Dr. Ritu Joshi, ma'am. Welcome, ma'am.
Thank you very much for the lovely introduction. And just a second, I'm just going to try my slideshow, huh? Give me a second.
No problem,
ma'am. I'm just finding out how do I get on to the slideshow.
Share screen button icon, green button.
No, I've done all that. Okay. I've already done that.
Okay.
I just want the slideshow. It's not showing it.
But we are not able to see your screen still. We are not yet seeing your screen.
Which is a little surprising. Okay, let me close it again and get back.
Yeah, otherwise, Kiranjit, you have sent the slides is what you told me.
No, it hasn't reached Kiran. It's not getting uploaded. Okay. Give me a minute.
Yeah, sure, ma'am. Sure.
I'm just getting on.
Yeah. Not yet. Not yet. Not yet, ma'am. Can you send the slides to me? I will play it for you. Or I have some presentation which okay. Dr. Sarita has joined. Has Dr. Sarita Agrawal joined? Has Dr. Sarita joined?
Not yet, ma'am.
Okay. I must call her then. Why she hasn't joined?
So maybe then move on to Dr. Pratima Mittal. If we can start her session.
Yeah. Why not? Just
Dr.
wait for till Dr. Ritu says so, because I think she's trying. Hello, Dr. Ritu. Ritu ma'am. Yeah. Ma'am, is it possible? Unmute करिए. Unmute हो गया? Can you, Kiranjit, can you put it in the group? Ask Dr. Sarita whether she has joined.
Okay, ma'am.
And I'm not able to reach her number. Yeah.
I'll try and call her.
Yeah. Ritu madam, क्या करें? No. I think it's best to proceed with Dr. Pratima Mittal's presentation, because
Can you see them now?
no ma'am.
Then what is the reason?
आपने share screen किया है?
Of course, everything is done.
It is the internet issue, isn't it? Kiranjit, where is your technical support person? It's an internet speed which is hampering you. That's what I feel.
Yeah, because even earlier when I showed her the slides, it took a little time to come.
So can we proceed with Dr. Pratima's presentation?
Of course, please do that. Please do that. Let's not
Thank you
waste
very
time.
much. Thank you very much, ma'am.
Thank you,
I'll
ma'am.
join again by sending her the slides.
Yeah. And
Thank
you
you, ma'am.
please send me your presentation.
I'm just
Ritu ma'am, yeah, please send me. Yeah.
So, ma'am, can we
please
go
go.
on to Dr. Pratima's session?
Yes, please.
Okay, thank
Please.
you, ma'am. I'd like to invite Dr. Pratima Mittal, who's professor of OB and Gynae, VMMC and Safdarjung Hospital, New Delhi. She is an expert in high-risk care and critical care. She will be speaking on essential youth-friendly reproductive health services and counseling during COVID-19 pandemic. Ma'am, Pratima ma'am, please welcome.
Hello, can I share this screen?
Yeah, ma'am, your screen is visible.
Okay, so I'll make it full slideshow.
Yeah.
Okay.
Yeah.
Good afternoon, everybody. First of all, I would like to thank UNFPA, then PGI Chandigarh, and of course our Foxy for giving me an opportunity to be, part of this forum. And I will be talking on essential youth-friendly reproductive services and counseling during pandemic, COVID-19 pandemic. So coming to my, talk, first of all, I would like to just discuss the issue of, see, it is. So we all know the adolescent population in India. There are about 253 million of adolescents in India. And the updated global strategy now includes adolescents also in their, SDG goals, because adolescents are the central to everything we want to achieve and to the overall success of 2030 agenda. So what is the, vulnerability and of the adolescent here? Adolescents are the 10 to 19 years, and youth is taken as 15 to 24 years as per MOHFW definition. And I will be using these terms synonymously, either adolescent or youth, because most of the problems are common and most of the issues are commonly dealt, except few issues which are on the early adolescent, which we can deal separately, but most of the issues are common, so I will be using these terms synonymously. So the vulnerability of adolescent is for medical conditions like anemia, then there is early marriage, then which leads to teenage pregnancies also, and then contraceptive use, which is very much less. There is the unmet need, which is very high, and then substance misuse, which is the problem, and of course the life-threatening situations like tendency for suicides. So all these issues, psychological problem, emotional problems, physical problems, sexual problems, all these issues are very, very important for adolescents. And what I will be focusing on, as has been told earlier also, first, what are the services we were giving before pandemic? That Dr. Kirti also addressed this a little bit. And so I will be talking about services before pandemic, then essential services during pandemic. What are the essential services to be provided during pandemic? What are the challenges faced? What are the services really provided during pandemic? And what should be a gynecologist focus? So coming to the first thing, in our, India, there is a program which is RKSK program, which has been launched by the government of India in 2014, and it was revised in 2018. And this has really taken care, this is a dedicated program which is taking care of the adolescents and youth of our country. In this program, the key issues are to improve the sexual and reproductive health, to improve nutrition, address non-communicable disease, prevent substance misuse, prevent injuries and violence, and enhance mental health. And we have got guides and implementation guide, operational guides, facilitator guide for this, training of youths, as well as training of all the healthcare personnel involved in this program. So other issue is how do you approach? The approach is either facility based, which is through adolescent friendly health centers, or it is community based or school health approach. Adolescent friendly health centers are providing counseling and clinical services, and there are adolescent health resource centers at district hospitals also. Community based approach and school based approach focus on weekly iron folic acid supplementation, WIFS program, deworming, provision of sanitary napkins. Then there are peer educator programs, Sathya, and their quarterly adolescent health days, which are being celebrated. But the main aim is the health promotion and prevention of the activities which are not healthy for the adolescent. Just in this short, I would like to say what the progress has been made under RKSK till now before COVID. There were adolescent friendly health clinics set up. Since the inception, there were 8,018 clinics have been established, and more than 7 million clients registered in 2019-20. But due to COVID, the registered number in the first quarter of 2021 is decreased, only 400,000 clients registered. WIFS targets about 119 million children in and out of school, and in the first year 34.5% of target population was reached. But in COVID year, in this 21, only 4.8% of the population was reached. Similarly, peer educator program, which is not really suffered, but the WIFS program and other programs have suffered. In peer educator program, there is 340,000 peer was selected, and out of 50, more than 50% are trained already. And they have conducted more than 15,000 adolescent health day in 2019-20. But this time, due to COVID, only 161 adolescent health days were celebrated, in all over the country. And lot of funds have been, released for the states for the menstrual health scheme. And for this, more than 50 million girls were covered in 1920, but the number has reduced this year to about 2.2 million. So you see broadly that the coverage, the footfall of all these services for the adolescents have really gone down during COVID pandemic. And a little bit about these adolescent friendly health clinics, because these are the backbone of dedicated adolescent health friendly services. So in this there have been guidelines which have been established, which are standard guidelines which tell us how to reorganize the existing space, how to decide the service package, what are the standard clinical procedures which should be followed, strengthen skills of the teams of the healthcare provider, how do you strengthen it, and outreach activities are also decided. And monitoring is done by monitoring the clinic performer. Foxy also made guidelines for establishing these clinics, and this we in Delhi also only we established about 10 adolescent friendly clinics in private sector through Foxy accreditation, and in this Foxy guidelines were made for establishing this center in 2010. And next is the facilities. In these clinics, there is facilities, promotional, screening, clinical and prevention facilities are there, which have to be, implemented, which has to be available, because this is a comprehensive clinic for all adolescents with a holistic approach. And the services, the services should be of quality services, because there's standards which have been set by the government of India as well as by WHO, that these services should be accessible, should be acceptable, should be equitable for both poor and rich, for girls and boys, should be appropriate what they need. They should be, really given that advice or management treatment. They should be comprehensive and should be effective. So when we talk of these services, there is service package which is been decided, which has been standardized, which should be available in these services, and there are SOPs which have been standardized. There is an adolescent job aid, which tells us that if there is a patient is approaching to you, how to go about then adolescent client, how to maintain privacy, how to maintain confidentiality, and how to maintain the quality counseling services. Now comes this, we have talked about the available facilities for adolescents, dedicated available facilities for adolescents, but none came this pandemic. And what did the WHO say? WHO guidance on maintaining healthcare in the context of COVID-19 addresses that all population and segments and all health issues should be addressed to. There should be maintenance of essential health services, operational guidance which was issued by WHO in April itself. And the Lancet also, Lancet Commission with the Guttmacher, Lancet Commission advocated that there should be provision of comprehensive sexuality education, because it said that this, they are not on pause. The adolescents are not on pause. They should be provided all the reproductive and sexual health services. So they said that it should be, the commission advocated that it should provide, every country should provide comprehensive sexuality education, provision of contraceptive counseling and services, mainly 8 components: provision of comprehensive abortion care, prevention, care and response to sexual and gender-based violence, provision of antepartum, intrapartum and postnatal care, provision and treatment of HIV and other STIs, and prevention of cervical cancer, as well as menstrual health, hygiene, information and products. We have to understand that adolescents and youths are a heterogeneous population. They can be married and unmarried adolescents and youth in the group which we have to address. They can be poor and rich. So our services should be designed according to their needs and individualized according to their needs. Then the government of India, as per the WHO verdict, the government of India also issued a guidance note which said that adolescent health services have to be included into the into the essential health services. They have to be provided, and but their approach can be modified. Their approach can be delivered in a different way. So for that, the facility mapping and planning and what is advised. Alternate service delivery mechanisms were developed, like telehealth, modified outreach activities, home visits, etc., triaging, management of human resources, and ensuring supplies of medicine and diagnostics. Here, I would just like to thank Dr. Rosa, the Deputy Commissioner of Adolescent Health at Ministry of Health and Family Welfare, who has shared these slides with me regarding the activities of Ministry for the adolescent health. The challenges faced in continuation of these services during COVID-19 are, again, we have talked about these in a little bit, but the increased vulnerability of adolescents, we all know that because of the age, developmental status and attitude, they are vulnerable. So many things, they've not got a capacity to emotionally not mature to handle all the problems. services are disrupted. Health services, their midday meal programs in the schools are also disrupted, so their nutrition is also suffering. Movement is restricted. Financial unemployment for the elderly adolescents or youths, that is also leading to the financial problems. Then social fear of getting the disease, so it is leading to less of intermingling, and there is a stress due to social isolation. So all these challenges are faced in the continuation of providing essential services during COVID-19. So how do you meet them? How do you address these challenges? Basically, we have to prioritize RM and CAX services. We have to reorganize services using telecounseling, using video counseling, appointment with safety. If you're giving it the face-to-face appointment, it should be with safety, focused group discussions, involvement of NGOs, involvement of pharmacists, use of outreach and mobile vans, digital monitoring, very, very important. But here, one thing we have to always consider, that no compromise should be made on the quality of the services. Quality of the services have to be maintained. The government of India has done many programs, many activities, modified their activities. Counselors in AFHCs are continuing to work regularly. They have not stopped working. They are conducting teleconsultation of adolescents and provide services on demand to walk-in beneficiaries in containment zones with special focus on mental health. And many of the counselors have said that there are large number of adolescents and youths who are coming with mental health problems. AFHC have to remains fully operational outside the containment zone, and Adolescent Health Day is being celebrated. You can see here in a difficult Himachal area, this is the picture where Adolescent Health Day is being celebrated, but of course with the social distancing, and then they are saying, telling them how to wash hands, how to keep, wear mask. All these things have been taught in that adolescent health programs. Then again, supplies have to be delivered, like IFA tablets and sanitary napkins. And for this, AAA approach is being done. That is, they are using ASHA, Anganwadi workers and ANMs for these services. And schools are mostly closed, so these services are done on the community basis as well as on the area designated to these healthcare workers. Then the government is also getting a lot of support from civil society organization partners on the ground, and they are also facilitating the distribution of all these essential medicines and pads, sanitary napkins, etc. Other Government of India digital initiative are very, very important. That is the integrated government online teaching, IGOT, which is a single point of access to the repository of training resources. So it is all, all the training resources are at a single point of access. And Ministry of Education, Diksha Proforma platform is there for the capacity building of teachers as well as for healthcare workers. So this platform is being used for training. Then there is e-Sanjeevani OPD, where where confidentiality is maintained, because the adolescent can talk directly to the doctor after taking the appointment on the telephone, on the video, computers or on the phone, and they can maintain confidentially by not even disclosing their name or anything, but they can really talk to them, and that doctor can help them in deciding where to go whenever, if they feel that the person needs to be seeing some healthcare worker, healthcare personnel personally. Then helplines have been set up, especially in the states like Odisha, Kerala, and MP. Virtual review meetings of the state nodal officer is done by the ministry, and the progress is being observed. And web-based assessment of the laboratory districts. Laboratory districts is mainly the districts which are in the remote areas, very, very remote areas where all these RKSK implementation programs are being going on. And mobile apps have been developed, but on the universal adaptation of these mobile apps for for the adolescents is under investigation. It needs further evaluation. And of course, these digital platforms have helped many adolescents overcome the isolation and loneliness and lack of physical interactions. But it is still digital. Platform is digital, and as we are conducting this webinar, they're nothing like the face-to-face webinars. So, and again, besides that, Government of India is also, advocating the training of the state nodal officers, which is continuing on the web platforms. Young people are being a two-part webinar series on fostering well-being and resilience among adolescents. And during and after the COVID have been conducted for state program officers, and mental health issues, how to handle those issues have been taught to them. And they are especially focusing on the specific vulnerability of these groups during the pandemic, and strategic and effective ways to promote their well-being. Then virtual training of state resource group is also being done by various training. In this, the main issues are, being considered are the growth and how to grow healthy, how to, eat healthy, what are the reproductive and health issues, how to promote the healthy lifestyle. So all these things are being trained to the state resource group by the virtual training. And school health and wellness ambassador initiative is also taken, that is SHWA. In this, 2 teachers from each school have been trained, and those teachers can, because the classes are on the virtual platform, so these teachers are also these ambassador the teachers are also using this classroom approach for on the virtual platform for educating them about the adolescent issues, about the health issues. And NCRT training is also launched by the minister in the February 12th, 2020. And this will be implemented in most of the schools. And the expected coverage is about more than 1 lakh schools in the country. And even though COVID is there, this program is going on, and these trainings are being going on. This advocacy material for SHWA, that School Health Ambassador Program, is has been developed, and this is being distributed to the students, again on the digital platform only. So and as far as Delhi is concerned, we have a WHO Collaborative Center for Training and Research in Adolescent Health at LHMC, where the clinical services are continued. Training is being conducted by webinars for medical students and pediatrician, and for nurses also. And as research is going on, this data has been provided to me by Dr. Harish Pemde, who is in charge of the WHO Collaborative Center of Training at LHMC. But we as a gynecologist, what are we doing? What we have to do? Our role is providing the essential services to adolescents. So what are the services which we mainly focus on the antenatal, intrapartum and postnatal services for the pregnant adolescents, for comprehensive abortion services, comprehensive sexuality education, and violence against women. These are the 4 important issues which we have to address, besides the other contraceptives and immunization services. So in this, when we talk of the antenatal care, there are modifications. The redesigning of antenatal care has been there. The focus is on identifying the high-risk pregnancies, modifying the schedule, replace the ANC with the home visits. See, you can see this OPD slip. We have started a telemedicine clinic in which the antenatal care is being done. After the first visit, the antenatal care can be done by the telephone. They have got a WhatsApp group. They send us the reports on the WhatsApp group, and then the guidance is given to them on the WhatsApp itself, and the prescription is given to them. This is being followed, and Lady Harding, Safdarjung has not started it, but we are in the pipeline to start such services on for antenatal care also. Intrapartum care, of course, we have to modify by making it a triage area, by making an isolation areas, and taking all the precautions of all doctors wearing the proper PPE, and every patient is taken as a COVID positive patients as far as the universal precautions are concerned. And all the patients are being being tested for COVID-19 when they are coming in labor. As far as the postnatal care is concerned, it should be given within 24 hours. In today's scenario, we are discharging the patient a little earlier than waiting them for 48 hours, because so that the overcrowding is less. And of course, the development of referral and emergency transport is focused upon. Then coming to abortion services, one has to understand, and we are also advocating this, that all the legal documents have to be completed before any abortion services are being provided to them. Medical abortion, now the government is saying that you can give medical abortion on teleprescription, but I have a very little experience on that. We have not, till now, we are not giving that. And we, of course, at every point, we have to offer psychosocial support and to the clients, to all the adolescent and youth clients, especially because they maybe social isolation leads to a lot of stress, which may lead to problem. Comprehensive sexuality education, main focus is on counseling, how to do counseling. I will be talking in my few slides later on this. Then violence against women, media, creating awareness by NGOs, Foxys, etc. is very, very important. It has been dealt by Foxy in many webinars, but I will just like to highlight a few issues about violence, and then I'll talk about counseling on especially sexuality education, how to do that. Violence against women definitely has increased because of the stress. People stay at home, families, and spend more time in close contact. Exposure to violence increases, resources become less, disruption of livelihood, economic activities will decrease access to basic needs, then it will increase more stress, and it will lead to more violence, conflicts and violence. Perpetrator may restrict access to items such as soap and hand sanitizer also, and may exert control by spreading misinformation. Similarly, access to services is decreased, and other services, hotline, crisis centers, they are also reduced. There is, may also be, difficult to access to there, because there are few resources are there to help in that accessment of that services. So what can we do? We have to train our health workers, who have to identify the adolescents who are having such type of problems, who have to identify them. First line support have to be given to them, and they have to this life support, this have to be taught to all our healthcare workers regarding how to identify the woman who is suffering from, women or adolescent or youth who is suffering from domestic violence or sexual violence. And besides that, the adolescent herself have to be empowered, like for reducing stress, seek information from, they should be told that they seek information from reliable sources, seek support from family and friends via phone, email, maintain daily routine, use relaxation exercise, engage in activities that help you manage in adverse events. Stay safe during an argument. Try not to draw attention to yourself, and inform and arrange trusted friends when you have some real issues, so that they, you can get their attention, and you can get the access to proper services, proper health care services. Coming to counseling, the early adolescents, most of the adolescents come to us with the problems like, I am short, I am tall, I am very thin, or I am very fat, I am not having miscarriages, my breasts are small, I am having a lot of pain, I am not able to go to school, I am having a lot of discharge, acne. So all these problems, if you understand, we have to really, really counsel them. Most of the adolescents are physically healthy. It is mainly the perception of these adolescents of a normal phenomena, which they take it as abnormal. So we have to identify them, identify their problem, tell them that this is not abnormal, this is the normal physiology, this is the normal normal expectation from you, like height is concerned. So we have to inform that this is, the mother may be tall, the father may be short, so all these things are important. So they basically, counseling in such subjects is the most important things. And besides that, we have to advise, basically focus on privacy, confidentiality, as well as availability of iron and folic acid and menstrual hygiene products. All those things should be seen for all the adolescents. But coming to these sexual issues, I have got few scenarios which have been come to me recently only. Like a 16-year-old boy comes to you saying that he masturbates every time a day and worried that he will become impotent, so he cannot stop. So how will you counsel this boy? Explain to him the physiology of sperm production, give scientific evidence, Tell him the incidence of masturbation, about 100% in those who say no are lying. Give him authentic literature to read. So all these things are very, very important. Scenario-wise, individualized counseling, keeping the privacy, keeping the confidentiality has to be seen. Another patient who comes to me, 18-year-old girl, comes to her, she says that I have got engaged to be married and my fiancé is pressing me to have sex with him. So what you as a counselor, what you as a healthcare provider do, you have to promote concept of marriage, abstinence before marriage and abstinence. Risk of premarital has to be explained. Explain her uncertainty of future. Explain feelings are involuntary, behavior is involuntary action. Explain that mutual respect for each other is important. Let them decide. If still decision is yet, promote safe sex. So mainly thing is you can just tell them the advantages and disadvantages, but the decision has to be the adolescent himself, otherwise himself or herself. Otherwise it will have no value. Another boy who came to us, he has a girlfriend, all his friends are pressuring him to have sex with her. So again, all these issues have to be explained to that boy. The other problems which girls have come to us, that she had unprotected sex last night. She came to me, she was just crying and she's worried that she may become pregnant. So in these cases, again, very, very important that we have to be non-judgmental. We cannot say that you have done everything right. You have, you just take it as it is, be non-judgmental, do not say that it is wrong or right. Even if you yourself are feeling so, tell her about the consequences of unsafe sex, provide her with emergency contraception, screen for STI, promote safe sex. That's how important counseling is. So counseling in a proper manner and in a individualized manner with non-judgmental way, keeping privacy, keeping confidentiality is very, very important. So at the end, I would just say that COVID-19 crisis is a threat to the adolescents. All the utilization of services coming down, but it is also an opportunity by use of telemedicine, digital media. And I am sure that strong will and quality skill will make impossible to I am possible. So everything is possible. I think we can really help our adolescents in this crisis period. Thank you very much.
Thank you, ma'am, for a very comprehensive evaluation of adolescent sexual and youth problems. And although this is a very neglected group, but I think the government of India is doing a very good job. And
Yes.
They have started a number of programs even during the COVID-19 pandemic. So the only thing is that everybody has to become aware and sensitized to this problem.
Another thing which I forgot to mention is that even Foxy is also starting a program with the aid of USAID. That is the shop program with us. It's starting in 3-4 districts. First in Delhi, Gurgaon, and Farida, I think Noida. So in that they are focusing in all these issues. They are focusing on development of youth-friendly services. So all these issues are being taken up. So Foxy is going in a big way into this program.
So that is great, ma'am. I think we'll have a lot of questions during the panel discussion.
Yes, we will. Yeah. Thank you, Pratima ma'am. That was really elaborate and well covered. Really a subject which requires a lot of introspection on our part also. Yeah, please kindly go ahead, Dr. Neena.
Yeah, thank you, ma'am. Now I'd like to invite Dr. Ritu Joshi for her talk on self-care interventions for sexual and reproductive health and clinical aspects of emergency contraception. Ma'am, Dr. Ritu, ma'am.
Oh, excellent. Thank you. Very nice.
So it started coming?
Yes, we can see.
Okay, great. So we're going to talk about the clinical aspects of the prospective emergency contraception. And I think as far as the pandemic time period is concerned, this is one of the best contraceptive methods which can be used to prevent unintended pregnancy. Now, no woman can call herself free until she can choose consciously whether she will or she will not be a mother. So we all know that the contraceptive methods are influenced by the interdependent demographic, cultural, economic, social approaches which are there. But India is actually fortunately the first country which adopted an official family planning policy programs which they had started, but unfortunately, despite starting being the first ones, we've not been able to reach anywhere near the goal which we actually should have been by now. So in India, the population is 1.31 billion already, but our prevalence rate is only 56%. We have more than people not using contraceptive methods. Every year, we have approximately 85 million women who have unintended pregnancies. More than 1 in 7 of them are in our country itself, and 46 million unwanted pregnancies end in abortions every year. And there was a very interesting study by Singh et al., which was published in Lancet, and that's really become a historic study in which we find that almost medical abortions outside of the facilities were almost 34.4%, and 32.5% were lower bound, and the 36.6% was in the upper. And it has been estimated to be a very high rate in our country. Sorry. Oh, I'm going back. So how do we tackle this problem? We have effective contraceptive methods available, and one of them which we'll be discussing today is going to be the emergency contraceptive pills, which have actually been underutilized in our country, and they should be used more often, and we should actually promote this more often in our day-to-day practice whenever we have women. You have to realize that it almost reduces 8% of the maternal mortality. So with the use of an effective contraceptive methods, 90% of the abortions, 20% of the pregnancies related to them can be taken care of, and these are largely underutilized, so we could make use of them by promoting it to the health professionals at all levels have ethical and legal obligations to respect a woman's choice, and that's what precisely we plan to do. Now, what is emergency contraception? It is a method of contraception which is taken as an emergency step just before menstruation is missed to prevent pregnancy following an unprotected sexual intercourse. So they are popularly also known as the morning after pills. They decrease the risk of pregnancy after intercourse before establishment of a pregnancy. They are that's the self-explanatory term which we are using, and there is a need for urgent and timely action. Need has arisen out of an untoward incident, example the contraceptive accident or a sexual assault or unprotected intercourse. I remember as a family welfare committee chairperson when we were talking about contraception, and that time when this emergency contraception had come on the scene, we always used to tell the police people that when you have a rape case, at least have this emergency contraception there, that you can give it to her immediately to prevent an unintended pregnancy or unwanted pregnancy. Then it is not, remember very closely that it is not meant for routine use or a repeated use. So basically, you always need a backup method after using the emergency contraception. So in what situations it can be used? It can be used after intercourse when no contraception was employed. That means unprotected intercourse. The method was used imperfectly. That is, using a barrier method, the condom either slips or it's broken, or you miss out on the injectables which you were taking. Then the sex was forced without the use of a contraceptive method. These are the wonderful method of preventing unintended pregnancy. They are also indicated when no contraceptive was used and it was used incorrectly, or a method was used correctly but was not immediately taken care of. So what does an emergency contraception actually means? It just prevents pregnancy by occurring after an episode of unprotected intercourse, but it does not interrupt an existing pregnancy. So always remember that an emergency contraceptive pill is not an abortion pill. So we need a backup method, and it is not to be given once a pregnancy has been diagnosed. To be effective, it should be given within a specific time interval, not meant to be used as a regular contraceptive method. It acts according to the day of the menstrual cycle it has been used, the time in the menstrual cycle that it has been used, works by disrupting the timing of ovulation or preventing fertilization of ovulated ovum. It is not an abortifacient. That is something which we all will go on and on emphasizing upon. So if we see that the effectiveness of the emergency contraceptive pills, now if there are 100 women, no emergency contraceptive pill has been taken, they would land up in 8 pregnancies, unintended pregnancies. But a progesterone only emergency contraceptive pill has been taken. We have only 1. That means we prevented those 7 unintended pregnancies. And if we used a combined oral progesterone emergency pill, then we are preventing 2 pregnancies. What are the methods available to us today? We have selective progesterone receptor modulators available, which has recently become available in our country. We have progestin only method available. Then we have combined estrogen progesterone method. If you remember all, when I think we were PG students, when none of the emergency contraceptive methods were available, we all used to guide our patients to take the routine contraceptive pills in a very high dose. I remember telling them to take it at 2 tablets twice a day for 2 days, and which really used to lead to a lot of nausea and vomiting, but that could help in preventing unintended pregnancy. Now, we also have a use of copper IUCDs, which are there. So the selective contraceptive receptors can be used up to 5 days, which is fantastic. The progesterone only is up to 3 days. Then we have combined ones which could be used up to 5 days, and the copper IUCDs can be used up to 5 days of the unprotected sexual activity. Looking into a few clinical considerations, it is recommended that you have to give it at the right time. The timing of the presentation of the unprotected intercourse should not be more than 5 days. The patient factors also are important. We've got to realize, are they allergic to that? Have they any other concurrent medical disorders with them, or obesity? Sometimes, the dosage might not be adequate according to the weight of the patient, and of course the availability. So timing of the unprotected intercourse, if it has been taken, all the methods are very highly effective used within 72 hours of unprotected intercourse. Like the LNG can be administered before 72, and after it is less effective. And it is not currently labeled as, it is off the counter label. The copper IUCD does not decrease in efficacy over 120 hours. While if the weight of the woman is more than 30 kgs, BMI is more than 30 kgs per meter square, it is not considered a contraindication, but we must also realize that it may not be that effective, and we must give her another protective measure. So these are the methods available to us, and we must make full use of them. Let's talk about the combined oral contraceptives, which I was talking earlier, that we used to give them in very high doses to our women. Routinely, I remember we used to have a lot of overall L's available at that time, and we used to tell them that to take 2 tablets of it, and 2 in the morning, 2 in the evening for 24 hours, for 2 days. Now, that means almost given in a dose of 100 micrograms of estradiol and 1 milligram of norgestrel, 2 doses 12 hours apart within the 72 hours of unprotected intercourse. Earlier, they did have an off-label prescription of combined preparations, but we were giving it to them. They are less effective and produce more side effects, as I mentioned earlier, that they do cause nausea and vomiting a lot. And they should be reserved for situations where people can't obtain the other emergency contraceptive pills. This was also called as the UZP method. It was the oldest form of the postcoital emergency contraception. This method involves 2 pills, which I've already spoken about. This method works by delaying or inhibiting ovulation when utilized during the first half of the menstrual cycle. It is also effective if follicles are not already well developed. So a lot of studies have been done, and one found that the UZP's method had a failure rate of only 1.7%, and rest of them had it in different studies were very high. And So the efficacy of this is after a single act of unprotected intercourse, the method fails in about 2 of women who used it correctly. So the crude failure rate is about 1 to 5 per 100 women. And it means that if 100 women have intercourse in the mid 2 weeks of their cycle, approximately 8 will become pregnant. Use of emergency contraceptive pills would reduce this number to 2, if it that means almost by 75%. This was a very interesting study being done in the year 1997. But there were a lot of side effects. Most of the women developed the nausea, vomiting. So you could give them antiemetics at that time. They also did change the menstrual cycle because you're giving them very high dose, and they led to a lot of mastalgia as well as increased risk of venous thrombosis had been observed in them. The second method is the progesterone only pill, which is levonorgestrel in the dose of 1.5 milligrams, available in 2 doses of 0.75 milligrams each, and they are to be taken up to 72 hours of unprotected intercourse. But the off-label can be taken even up to 120. They do have a little established efficacy for that. So this method has been licensed, and we do have a single or a double dose tablets available, and this suppresses the luteinizing hormones, which delays or inhibits the ovulation. So in order to be effective, it must be administered before the LH surge begins. Otherwise, it is not going to be effective. Thus, reasonable to infer that LNG is less effective when given closer to the time of the ovulation. So there have been a lot of trials comparing the two, and they found that the LNG was far better off than the UZP regime which we were using, and it is very effective in a lot of women even when their weight was more than 70 kgs. The side effects of this was less, but there was nausea, vomiting. They did disrupt the menstrual cycle pattern, and when energy is taken in the pre-ovulatory menses, the length of the cycle may be abbreviated, or the length is unaffected, but duration of bleeding is elongated, so that the periods become for a very long time. We have another new one which has not been used, and the tablet of 10 to 25 is not yet available in our country. The meta-analysis of mifepristone showed that it is effective as LNG and more effective than the UZP method. The interesting study which came in Lancet in 2002 showed that the low dose mifepristone compared with two regimes of levonorgestrel, this showed that the low dose of mifepristone was equally effective to the single dose or the 2 doses, but rather leading to the conclusion that there is no difference in their efficacy. Both of them were very good when being taken. So I think a single dose of mifepristone would be far, far better to be taken. Now, this is an interesting one which is now being promoted by most of us also, is the ulipristal acetate. It is a selective progesterone receptor modulator, and a dose of 30 milligrams can be used up to 120 hours after the unprotected intercourse. Because, sometimes when we are very happy to have the copper IUCD, but sometimes the woman cannot reach the healthcare provider to get it inserted. This tablet, when available, is fantastic. Women are advised to use a barrier method or an abstinence from vaginal intercourse for at least 5 days after taking ulipristal, and it acts by inhibiting the follicular rupture even after the level of the luteinizing hormone has started to increase. The progestin increases. The contraceptive should not be used with ulipristal or for 5 days after the administration, because it can interfere with its action. We have copper IUCD, the most effective method for emergency contraception. It can be used up to 5 days after the unprotected intercourse. It has the advantage of providing to be a long-term contraceptive method, because once being used as emergency pills, you need a backup method of the other contraceptive methods. In this, you do not need that. So the main mechanism, how it acts by inhibiting fertilization, as the copper ions released from the device have a toxic effect on the sperm and the ova, and where fertilization does occur, implantation is prevented by it. So it acts both by pre-fertilization and the post-fertilization actions. Various people have done different trials, and everyone found that the failure rate was very low, and so it is very, very effective. This is another study which come across and also says that IUCD are highly effective methods after unprotected intercourse. The side effects, we are all very well aware of all the copy insertions which we always do. We find there is pain during the insertion process and increased menstrual bleeding, but both of them can be taken care of. The limitation is, of course, to reach the healthcare provider, and so it remains to be underutilized. And the necessity of IUCD placement by a trained healthcare provider use of contraceptive pills, we must also counsel them, and we must counsel them properly about the emergency contraceptive pills, because again, by the same gather approach which could be there, the baseline risk of pregnancy, the woman should be evaluated for pregnancy. In case if she the risk is dependent upon whether she had sex in the fertile window, how many unprotected intercourse exposures were there in that same cycle, imperfect use of the contraceptive method. So we should also tell them that any woman who has had unprotected or underprotected vaginal intercourse and wishes to reduce her pregnancy, ask her to identify their fertile window period on the menstrual cycle, and then guide them how well it is going to be protect them. We also have the WHO MEC wheel with us, which helps us in guiding the women in whom we can give this, advise this method, and whom we cannot advise this method. So the factors which affect the ECP use is successful use of an emergency contraception requires accurate knowledge about the different EC methods and the right time of giving it to them. Unfortunately, despite awareness of the availability of the emergency contraception, knowledge about timing and appropriateness continues to be a major issue amongst all of us. Now, I would like to discuss a few special populations, which actually comes to us in our day-to-day OPD. Can we give it to an adolescent? Yes, it is safe. Can we give it in a breastfeeding woman? Yes, it is safe. The Center for the Disease Control and Prevention said that the medical eligibility criteria plays no restriction on the use of it, and the LNG passes into the breast milk in a minimum quantity. So they all can be given the ECs. The ECs, now remember very well, this flow diagram is very clear about it. Menstruation within 7 days of the expected period, if it's been taken, then it encourages the use of a regular method along with it. And if it is not, then please perform. If it does not occur in the 7 days of expected periods, please ask them to perform the urine pregnancy test. Is negative, we can wait easily, but if it is positive, we've got to guide them accordingly, that do they want this pregnancy to be continued or they want this pregnancy to be avoided. The efficacy and failure rates of the ECs are here. We find that the UZP method, the pregnancy rate the copper T prevents it almost from 99 to 100%, so which is very good. And the common concerns of the people who use the EC, we should explain to them also. Now, can we write it down and give it to them as healthcare providers prior to their even need for it? Of course, we can give it in advance to them, because then at least if they are going somewhere and if they at least have it in hand in their bags, they can at least control their unwanted pregnancy. Then can an oral EC be used again in the same cycle? Basically, the ulipristal and the LNG can be used multiple times in the same cycle, but always we should never encourage our women to do that, because their whole menstrual cycle, whole rhythm goes haywire, and initiation of a proven contraceptive method is always preferred. What if the oral medication is vomited? Well, vomiting is rare after the ulipristal and LNG, but repeated dose of EC within 3 hours of ingestion would be good if she vomits the emergency contraceptive pills. what happens to the menstrual cycle. And this is something which is very important for us to understand. In the Cochrane database in 2019 explained everything very clearly, that women using oral EC, menstrual period typically restarts within 1 week of the anticipated date, more common with the ulipristal and the LNG use. Menstrual delay is more common following the mifepristone. And irregular bleeding or spotting can also occur up to 1 month after the treatment resolves without, there's no need, it resolves on its own and does not need any treatment. The follow-up should be always there when we write it to them, and when we have these women coming back to us, that a routine counseling is there. Anticipate period within 3 weeks of the EC initiation, then perform the pregnancy test if it does not come within 3 weeks, and consult if there is heavy bleeding with abdominal pain, suspecting it to be ectopic pregnancy. So pregnancy test also should be performed if no periods till 3 weeks, and should be informed that use of oral ECs will not protect against future risk of pregnancy from further intercourse in the current menstrual cycle. If pregnancy occurs, it depends, you can continue with it. If you're not wanting it, you could get it terminated. Does it interfere with the future fertility? Well, it does not interfere or does not have a negative impact on the future fertility. Foxy, way back in 2003, only gave a statement that Foxy acknowledged the widespread availability of the contraception, emergency contraception, and it believes that emergency contraception deserves to be a part of reproductive healthcare services to avoid unplanned pregnancy and associated health benefits. Proper counseling is required regarding the menstrual irregularities will improve the compliance. We did have a few negative feedbacks in the media, but then ultimately everything has been cleared. These pills should be sold only on a doctor's prescription and all, but ultimately we know that we can give them off the counter also without our prescription. So need of the hour, according to the United Nations Population Fund, WHO and all, that advocacy for easy access to emergency contraceptives should be there. ECPs are safe and there are no absolute contraindications to their usage. Patient preference, provider capability and local availability will influence which options are far better for that particular candidate. So summarizing over here, EC refers to products that prevent pregnancy from occurring after an episode of unprotected intercourse. Ulipristal is more effective than levonorgestrel. Levonorgestrel is more effective than combined oral hormonal, and no clinical examination of pregnancy test is required before prescribing the ECs. Body weight certainly influences the effectiveness of the oral ECs and should be followed up with regular contraceptive method. Concluding here, the available methods in India, the UZP regime, high dose levonorgestrel, copper IUCDs, and yes, we are soon going to get the DCGI approval for the ulipristal, and the treatment should begin within the first 72 hours of the unprotected intercourse. The early emergency contraceptive treatment is to be started. If started in time, it is very effective. Mifepristone in low dose, unavailable in our country, and copper IUCDs are highly effective, but it need to be administered and followed up by highly qualified healthcare providers. Thank you very much.
Thank you, ma'am, for stressing on the importance of emergency contraception, especially it is the need of the hour during COVID-19 when the access to facilities is limited. And but the carry home message is that although it is a very safe method, it should not be used as a routine and it should be used only in emergency. Thank you, ma'am. Now I would like to invite Dr. Meenakshi Rohila, who's a professor in the Department of OB and Gynae.
Yeah, can I, Nina?
Yeah.
Dr. Sarita Agrawal has joined and she has a talk to give on.
Okay. So
there is a talk on integrated services, no? HIV.
Yeah, okay.
And
I think Dr. Sarita wanted to give it at the end.
No, I'm ready now. I'm ready now.
Okay. So sorry, Dr. Meenakshi. I'll just invite Dr. Sarita for her.
Okay, fine. It's no problem.
It should be okay, no? Meenakshi, is it okay?
Absolutely fine, ma'am. Absolutely.
Okay. Okay. Yeah, that was the order, so I thought we'll keep.
No,
to
ma'am,
the
it's
order.
actually probably she requested early that she wants to do it in the last.
Okay, okay.
It's fine, ma'am.
Okay, fine. Yeah.
So, Dr. Sarita, I would like to invite Dr. Sarita Agarwal, who's Associate Dean cum Professor and Head Department of OB-GYN in AIMS Raipur, Chhattisgarh. She'll be giving a talk on the topic Integrated Sexual and Reproductive Health and HIV Services. Welcome, ma'am, Dr. Sarita. Welcome, Dr. Sarita.
Yeah, hello. Am I
Hello.
audible?
Yes, ma'am, you are audible.
So I'm just taking over. Just to give me a few seconds. Yeah. Good evening, everyone. And I'm very much thankful to Dr. Shubha and the program organizer for this CME. It's really wonderful to join the session. And today's my topic is on the integrated sexual reproductive health and HIV services. Well, when we talk about the integrated sexual reproductive health and HIV services, what exactly we mean? Understanding before that, let me just describe what sexual and reproductive health means. If you go for the definition for the WHO, it is in a complete physical and mental and social health. It doesn't mean only the merely the absence of disease or infirmity as we define for any of the well-being. So, what exactly it implies for that every woman should have a safe sex life and should have the choice for regulation of their fertility. They should have right to access to appropriate health care services, and that should be available. They should be accessible, and feasible to them. So, talking about the integration part, let me introduce why we are talking about the integration of HIV services along with the reproductive health services. If you look at the HIV epidemic, it is concentrated to some key population. These key populations are mostly the sex workers, injectable drug user, and MSM. Apart from that, all the person who are affected with the RTI and STI, reproductive infections, they are again a vulnerable group for developing HIV. So they are mostly affected both HIV and RTI together. At the same time, if you look at the substantial proportion of the men and women of reproductive age group, they suffer from RTI and STI. And we all know HIV is primarily an STI. It is not only a vertical transmission or because of the injectable drug user. And the another important aspect in this, that RTI and STI, it predisposes or increases the risk of HIV acquisition to the extent of 2 to 3 fold. So it is very important that the women or the men attending the RTI and STI clinic, they should also be discussed about the risk of HIV and its associated problems in the future. Information, education, and counseling part, it requires to be included both for the RTI, STI, for the family planning, and for the HIV altogether. We'll be just going one by one and see how the integration can affect. We also know that the RTI, STI, and HIV, they share the common determinants like the economic inequality, the limited access to the appropriate information, there is gender inequality, there's harmful cultural norms and taboos which makes them a vulnerable or they create the social discrimination amongst them, and there is social marginalization of most of the vulnerable population. Looking into all this, there are many reasons to support the integration of reproductive sexual health and HIV and STI, because this integration system will be able to symmetrically tackle two of the most important challenges for the public health, and that will ultimately lead to halting of both HIV epidemics as well as the RTI and STI. These synergistic activity may be more efficiently work rather than having an isolated program for each of this. And because they share the so many common things, the common interventions, the common determinants, the common strategies and the policy to take care of or to affect the as a public health programs. See, what we look at the current scenarios. If you look at the HIV and AIDS services, like if you go to the VCTC services, they do not adequately address about the family planning and SRH services. Suppose if you go for the PMT-CT center, the women needs not only the prevention of the vertical transmission of HIV to her child, at the same time, sometimes she wants a termination of pregnancy because she doesn't want to follow all these intricacies of throughout the pregnancy, or if she is already having the children. In such cases, she may look for a safe abortion practices. But when the women is being offered for the safe abortion practices, we don't know. The healthcare worker may not know where to send, where the safe abortion can be available to her. Then the patient being diagnosed at the antenatal clinic to have an HIV positive. Now she needs to plan for her management throughout the delivery, where to deliver, how to deliver, and what immediate postpartum care she will need. If this antenatal clinic, which are being run in the periphery, in the rural India, by many of the our auxiliary nurses and the midwives, if they don't know, in such cases, these women who is being diagnosed as HIV positive may suffer lots of problem. Similarly, once the patient being delivered and she wants a contraception choice, such cases, if the coordinating person doesn't know where to send for the family planning and what family planning services she should be offered in form of the contraception, then that can be a biggest issue for the women. Similarly, if you look at the sexual and reproductive health clinics like an RTI and STI clinic, they don't discuss about the risk of the HIV, and therefore these women who are coming to this clinic may not be aware about the HIV. Therefore, these SRS services needs to address the HIV and AIDS issue also simultaneously. Integrated service delivery response, therefore, is a dual strategic goal, not only for ending the AIDS as a public health threat, but also aiming for the universal access to sexual and reproductive health. When we talk about the integration, what exactly we mean by that, the two or three programs together are being integrated in terms of right from the policy making, from the planning, from the training, to the supervision and monitoring, financial management, and ultimately the delivery of the healthcare approaches to the women at the grassroots level. This system for the integrated policy and management may be different for the primary healthcare center, for the community center, and for the district level, which actually needs a careful planning, which I will be discussing in the last part of my presentation. And for that, there are available operational manual for delivery of HIV prevention care along with the reproductive health care, which defines clearly what is integration, what is linkage, and what exactly we mean by triaging. Most of the time, the integration and linkages are taken as interchangeably, but this is not exactly an interchangeable word. There is definite meaning of that. By integration, we mean that we deliver the services or multiple intervention together on the same patient visit in one place only. This one place may be a single room with a single provider, or it may be the same place with the different rooms and the different providers, and there's a clinical team. So maybe sometimes a single provider, if you want to teach, let her to understand the skill about all these aspects, may be a difficult task for that person. So if you have a different rooms with a different provider, we have, and they are been working very coordinated, then definitely that can be a more help. So it is a one-stop shop when you talk about the integration, but it doesn't mean that all the services will be provided to them on the on-site delivery. For example, suppose a woman is being diagnosed with an HIV and she needs some family planning services. It doesn't mean the family planning facility in the form of abortion, safe abortion operation theater should be available on the same site. Rather, we should have a linkages, we should have a referral practice. So the worker, the healthcare provider at the first clinic will be in linkaging this to the other centers. So the linkages, literal meaning is connections, relationship. These linkages can be between the health center and services, between within the hospital itself, or between the clinicians, labs, and pharmacy. Similarly, if you look at the PMTCT, the antenatal clinic, the VCTC centers are there. And then the HIV being diagnosed, it doesn't necessarily mean that the ART should be provided on the same center. And antiretroviral drugs should be provided in the same center. But an appropriate link, this women can be linked to the ART center. Once she's been diagnosed, this ART center will take care of her further needs in the form of tracing for the co-infection, tracing for the RTI, STI, and providing her the antiretroviral drug and follow up with the drug toxicity, etc. So this linkage services actually reduces the burden on the part of the primary provider. And this linkage is not necessarily can always be with the government. Even the public private linkages are now flourishing a lot, and it is of a specific use in the remote area where the much of the government services are not available, or maybe even like a person living in the urban slums where the public private partnership linkages can be of great help. At the same time, it also describes the triaging. That means sorting out the priority patient based upon the resources available. I'll be just discussing a little bit later about this triaging. So, the UNICEF, the World Health Organization, the UNFPA all identify integration of the health services as the key services to provide a continuum of preventive and curative services according to the public needs over the time and across the different level of the healthcare services. And it has been very well given in this manual, which is been depicted here. And there are the innovative approaches. There are the experiences with around 11 countries who have practiced these services, and they have shown their challenges and their what are the benefits. And looking at this, their experiences, of course, it can definitely help to develop and adopt a policy for our country or for the particular place where we want to integrate these services. So in integration of HIV and SRR services, it is a bidirectional referral. How I can explain, it's like diagnosis and treatment of sexually transmitted infection currently being provided at the designated STD clinics. And if you look at the respiratory tract infection, it is mostly provided by the obstetrics and gynecological OPD. These two services can be integrated if the STD clinics are being in the premises with the gynec and obstetric OPD, and their care can be taken, the patient can be delivered all the services at one stop. Similarly, if you look at the prevention of mother to child transmission of HIV, currently it is a part of HIV services. And the prenatal visit and delivery is a part of obstetrics and gynecological services. Now, the NECO has definitely combined this, integrated these two services together, and the most of the prenatal clinic or the antenatal clinic are now having their own VCTC or the PMTCT with the enriched with a counselor and the person who collects the samples to diagnose and confirm do the testing for the HIV. And the provider initiated testing and counseling being done in the antenatal clinic itself. Similarly, the family planning services are currently being provided at the family planning clinics, but this can also be integrated with the PMTCT, and therefore the woman gets the whole bundle of care at one go. Another thing, the which is rarely been provided to integrate is expanding voluntary counseling and testing center in the family planning services. We know we do have the Mary Stopes clinic sort of the clinics where the family they are meant for the family planning services. If these clinics are being integrated with the VCTC, the unwanted pregnancies, then they can take care of the transmission of HIV as well as the RTI and STI. Similarly, providing the family planning services in the HIV clinic. Then, if you go for the adolescent friendly clinics, here also these things are being least discussed. RTI, STI is usually discussed, but the HIV is being least discussed. So, integration of this VCTC, RTI, STI in the adolescent friendly clinic is also of a great advantage for the tackling this public health threat of HIV/AIDS and the STI and RTI. If you look at the bundle of services being provided on the RTI and STI clinics, that includes the IEC for the prevention of RTI, STI, then the client management, then the partner tracing and the partner notification, treatment of the patient, client as well as the partner, and the further follow-up schemes. And if you look at the PPTC program, it includes 4 prongs: primary prevention of HIV, especially among the women of the childbearing age, and also includes the adolescent age group by the IEC. Second prong include the preventing unintended pregnancy among the women living with the HIV through the family planning services. The third prong, that is preventing mother to child transmission of HIV to their child, which includes provider initiated counseling and testing, linkage with the ART clinic, antenatal, postnatal care, and the abortion services, STI tracing and management, screening for co infection, and linkage with the ART, information, education, and communication about the nutrition, the breastfeeding, RTI, STI, and of course, it includes the main involvement in the MCH care also. And then further linkage with the community based care and the support program for HIV and AIDS. And these 4 prongs of the HIV, PPTC, PMTCT, and the RTI care delivery system, STI care delivery system, incorporating the family planning definitely is a goal to reach to our goal of tackling these 2 health problems. Looking into that, the WHO call for action defines the 10 coordinated action which are urgently needed to advance the sexual and reproductive health rights and HIV life course needs of all the people. These 10 coordinated actions includes a meaningful community engagement, that the community needs to be involved, accountable leadership and the governance by the government and also the stakeholders, amendment of the harmful laws and policies which can be deterrents to these services, appropriate funding, coordination within and between the stakeholders, reorientation of the healthcare system, multi-sectoral partnership, right, and the human right based accessible quality services on the both SRH as well as the HIV. It needs promoting innovative approaches because this integration is quite demanding, and we may not be having done a straightforward policy. Yes, this is definitely going to help. Therefore, the innovative approaches needs to be done by the specific country level or on the state level, and then their experiences can be shared, and based upon that the innovative approaches can be implied and the program can be successful. This is about the prioritization, because we always know we do have the constraints, so the prioritization becomes an important. We know the women who need women and men for the STI, RT, and HIV are the people living with HIV, the sex workers, the transgender people, men who have sex with the men, people who use the drugs, people in the prisons and the close surroundings, and with the additional attention to the adolescent and the young key population. These can be the priority group where the initial integration policies can be adopted. In India, in Bihar and Andhra Pradesh, They had in a pilot project, like in a path study, and their results are quite promising in the key population where the integration has really helped in tackling the problem of the major health issues. If you look at this slide, this is very congested slide, but this is very important to have a great look on that. But the time constraint, I cannot explain how this is being very clearly told about the integration, how to do it, how to do the follow-up, and what are the constraints, what are the challenges. So it's time to study the linkage between the sexually transmitted infection and HIV. I think everybody was really interested into that. Go to the WHO website, and this circle slide diagram is available how it is to be integrated. It's not only WHO, but a number of international organization has commitment supporting the SRHR and HIV linkage, which include the Alma-Ata International Conference on Population Development, Client Cell to Pollen Action, Maputo Plan of Action, the UN Gas Declaration, the Political Declaration HIV and AIDS. And they all have ultimately describe the potential benefits of the integration, and it has been compiled by the UNFPA within one of the article where almost 11 studies are there and their own experiences are being shared, and it has come with improve with the results that the integration improves access to and uptake of key HIV SRS services. The services can be provided in the tailored manner. It avoids the stigma and the discrimination. It provides an improved coverage of the vulnerable population. It is being a great support for the dual protection from STI, RTA as well as HIV. It provides an improved quality of care. There's a decreased duplication of efforts and competition for the scarce resources, and this is of really a budget saving policy, and it preserves the individual rights. There's a, it overall it makes more efficient use of the resources for providing increased access to both HIV and the SRS services. If you look at certain examples in the Southern Africa study, the integration has shown to increase uptake of ART, increase utilization of family planning services, decrease workload on the health providers, and increase involvement of men in the ANC clinic visits. A systematic review has shown that if the ART being given and the ANC integration is being done, it has got to show of more coverage on the integrated clinic than in standalone clinics. Another Malawi study which showed the integration of immunization services with the early infant diagnosis, and there's a definitely threefold increase in the uptake of the infant HIV testing and the continuum of the care to the infants. And this way, the childhood HIV can be definitely eliminated. There are many such examples. However, when you talk about any of the innovation and the new policies, there are certain challenges, and these challenges are also depicted in this article. The main challenge is the provider behavioral change, because if you want to implement this integration policy, you need to change the behavior of the providers. We know the person who is providing is being accustomed to his or her own routine, may not be ready to accept the change, may not be ready to acquire the new skills for an additional strategy. It can be perceived as an imposition or threat, or be felt as overburdened. And we know that this attitude can never be helpful for a successful program. So these issues need to be addressed whenever we are implementing such program. Then the problems with the logistic for procuring and distributing. Of course, when the two or three programs are combined, then the human resources, the equipments, the instruments, and the coordinating and linking, they all have a logistic issues. Then the beneficiaries, the public, the population whom we are going to serve, they should have an adequate level of understanding. They should be able to respond adequately. At the same time, the they should have the then all discussion should be based upon their level of knowledge, their level of attitude, their level of risk perception, and the social stigma and all. So these are the three main challenges which still the countries are facing who are being implemented this integrated approach. And the question can be, is this ideal in theory, but actually not viable in practice? But I will like to explain any program in an initial phase can be not, looks like it is not sustainable. But if the program has a properly planned and it is addressed to meet the challenges of any program by learning the experiences by the previous organization who really implemented this and has recommended if to have if you want to have a successful integration of these two activities, these strategic proposal has to be coordinated, has to have a good collaboration and the effective participation to be involved, and there should be the strategic approach. This strategic approach is first one has to analyze the feasibility, the actual degree of acceptance of integration at different levels. One has to determine whether there is a drastic changes are required for the operating procedure. One has to spell out the logistic for the procuring and distributing these products. Then a drawing up a detailed budget has to be there, and then prepare a detailed description of services that must be offered. There should be clear-cut mention about the services which will be offered on these integrated center. Then define the public awareness and the training needs. And there's another important issue thing is that there should be a good communication program to ensure the public aware of the availability of these integrated programs, and that will definitely enhance the utilization of these integrated services. So this is a flow chart showing the inputs are the more enabling environment for a linked SRHR and HIV response, a stronger healthcare system, a more integrated delivery, and the outcomes are in the form of reduced HIV-related stigma and discrimination, increased access to and utilization, reduced gender-based violence, and improved program, and ultimately a very healthy and community with unsatisfying results. So, to end up with the conclusion, ending AIDS as a public health threat and ensuring universal access to the SRH are the two key targets for the Sustainable Development Goal 3. And as we journey toward 2030, integration of SRHR and HIV plays a pivotal role in improving health and well-being of all. Leave no one behind. Bringing together the SRHR and HIV requires a deliberate intervention and political commitments, capacity building, and infrastructure. A simple, narrow focus in integration without looking at the broader linkage may be a great failure. Thank you so much.
Thank you, ma'am. As you highlighted that integration of sexual and reproductive health services, RTI services with HIV services is a win-win situation for the healthcare providers as well as for the patients. But I think we have still to go a long way, and a lot of work is needed on this. So with that, I'll like to invite Dr. Meenakshi Rohila, who's a professor of OBGY in Department of Gynae in PGI Chandigarh. She'll share her views on clinical aspects of sexual and reproductive health problems in youth with us. I welcome you, Dr. Meenakshi. Dr. Meenakshi.
Thank you very much, Dr. Neena. Thank you for your kind words. I'm going to take a very crisp talk. Thanks to Dr. Pratima, who has almost covered everything about the youth-friendly services. I'll just share a few clinical aspects. Are my slides visible to all?
Yes, very much.
So just starting with the this term about the youth, as we discussed already, this is as discussed by Dr. Pratima, this is a broader term for youth that has been used by WHO. which includes adolescents plus the young people up to 24 years of age. So it's a broader term. Now, we would like to see, just before we start, that what is the clinical aspect and what are the problems with the young people. It's very important for all of us to see what is the data actually say about their reproductive health. So if we see the data from a recent survey of the 2020, if we see the marriage among the females between 18 to 20 years of age, we will see that it's already more than 37% of the females in the rural area are married. And if we see the 20 to 24 years of age group, the 65% women are already married in this age group. So apart from these early marriages, there are other additional issues also that I will present the data and the problem that about the contraception, abortion, risk of STI, HIV, what are their living conditions and what are the quality of healthcare they receive. So why it is difficult for the young people to access the services? Definitely the most important factor is the low autonomy. As we see in different surveys also, in the serial surveys also in our national level, we can see in our National Family Health Surveys that the women are definitely not able to take their decision about their own health. They are mostly, the decision about their own health are taken by jointly with the spouse, as we can see in this our survey also, and they are not allowed to go to health facility alone most of the time. They are only 50% of the women they are allowed to visit the health facility alone. So what are the other problems? The other problems are definitely, there are social norms also, there are providers' attitude also that may hamper many times a young people to visit a health facility. And health facility differentiation and the different levels of the health facility are also important for a woman to attend health facility. As we know, this is about the unintended pregnancies. So, whenever, sorry, my slides, I skipped the slide. So these are the basically health problems in the young people. As I discussed, the main problem is the pregnancy that may, if they at all they conceive, it is a very risky issue to a young mother, and it is risky to the newborn baby also. If they conceive and they do not want to continue pregnancy, they may land up in unsafe abortion. There are chances of having STI, RTI infection also, and that is including HIV in a young female. And there may be problems of sexual coercion also, where the woman can be forced by some unphysical means also to have sex with the people. Apart from these physical issues, there may be some mental health issues, and the drug abuse problems may also be there. So if they want to, if they continue pregnancy, definitely they face a higher risk of complication and death as a result of pregnancy. We can see in daily household surveys also, district level household surveys, that around 50% of the women are in this age group had complication after delivery, and it has been seen in the survey that they had one or more of the complication in the form of anemia, HIV, STI, PPH, some mental disorders like, most of the time it is a depression, and they may have some fistulas if the pregnancy remains undetected and unintended, and it is unsupervised pregnancy. If at all they continue this pregnancy, these are the complications. If they at all they do not, and it is an unintended pregnancy, again it is big problem. It may land up into perforated uterus if she does not go to a proper public facility or a private facility. It may land up into a postnatal hemorrhage, PID, infertility, and certain mental health issues also. So, and the other thing is about the need of the contraception. As Dr. Pratima said, we have a high unmet need for this in our married as well as unmarried females. We have seen this in our household surveys also. And actually a little progress has been made in the increasing uptake of the contraception, and mostly are affected by the discontinuation of the contraception. 40% of the women, more than 40% of the women have actually discontinued, maybe because of the one or more reason. So basically, these are the service needs of the young people under the sexual and reproductive health issues. They need to have a good information and counseling about sexuality, safe sex and reproductive health. They need to have a good counseling on sexual violence and abuse. They should have a service of the pregnancy testing, safe abortion, prevention of STI and HIV transmission. They should have a good access to a good maternity care, about the contraception and other mental health issues also. So these are the different features of a youth-friendly health services. These are mainly that has been covered by Dr. Pratima. I will just highlight few points that we have to maintain a privacy that has to be in the form of a visual as well as a auditory privacy. The healthcare worker has to ensure that we maintain a respect and confidentiality about this, and we should listen them attentively. They may be hesitant, they may be not very friendly to you in the beginning, and if as much as possible a wide range of reproductive health services should be provided to them in minimum visits, and informed choices should be given. Our attitude should be non-judgmental. Accurate technical information and informed choice should be available to them, and we should not be posing any unnecessary barriers to this service. We should be ready for other things, like if a client comes without any appointment and that person has an unplanned visit, that person definitely should be welcome, and they should be have access to a service. And as much as possible, they should not be allowed to wait, and the services should be affordable or as much as free as possible. So definitely, we have many challenges, we have many barriers in our society, and they are lying at the level of political level, they are at the society level, they are at the service level, and they are at the personal level too. So at the political level, youth are definitely given low priority in our society. We have a very strict laws and policies to follow, and at the society level, we do not approve sexual activities in this age group. We have a judgmental attitude towards them, and we have deficiency of youth-friendly services, and integration is also not there with prevention of sexual and sexually transmitted infection. At the personal level, definitely a woman, young people are less careful about their health-seeking behavior, maybe because of the fear, embarrassment, stigma, shame, and misinformation available to them. So what can we do and what can we help them? We can definitely make a good rapport with the client. We should be aware of this, that they may be anxious or they may be afraid of putting their problems to the healthcare workers, and they may be reluctant to disclose the information. So we should definitely make a good rapport initially before we taking history. And it's as far as possible, we should not be putting a direct question to them, and they should not be feeling threatened to our questions. And as far as physical examination is concerned, we should be having informed consent about them, about their age, and if they are young, if they are minor, we should be having a legal guardian with them. We should be explaining them what we are planning to do, and we should avoid doing physical examination if it is not management related, and we should avoid a judgmental attitude. We should reassure our client, and we should maintain our privacy. So these are the basically potential solutions and opportunities we can have to have a youth-friendly services. And as we discussed already, we should try to have a integrated services, and we should try to have a workers or providers who have a training to work with the youth. Sex education program we should try to scale them up. Post-abortion care services should also be trying to scale them up, and balanced contraceptive counseling should be available to them without any judgmental attitude. So these are the clinics. These are the, basically some government of India, a program by government of India that has been started, has been told in detail by Dr. Pratima. These are the Rashtriya Kishore Swasthya Karyakram that is available. And I just want to say one thing, that is our plan of the government is to shift from a clinical based services to a promotion and prevention based services in adolescent, and we are shifting from in and out of the school. So this is for the male as well as female and rural and urban area, and we are targeting married as well as unmarried females. And this is about sexual and reproductive health, nutrition, non-communicable disease, mental health, and drug abuse also. These are the clinic that we are already running. Benchmarks for these clinics these should be presentable. This should be, I mean, most of the things should be, it's good if we have a proper signage. They are mostly, if they are understood by the signage, because as to, adolescent may be very hesitant to ask. So it's better if it is well depicted and it is easily understandable, and we can maintain a privacy and confidentiality. This is another program that was already highlighted, that it is a peer educator program. We choose a peer from the group only, and that is adolescent may be friendly to that peer educator, and it's called as Sathiya. So Asha usually coordinate with this Sathiya, and we have a quarterly meeting also. These are the programs that are already going on by the government. This is another scheme that is going on where the aim is to provide awareness about the menstrual hygiene and access to good quality napkins and to have a safe disposal of napkins. So this is also coordinated and monitored by Asha, and at the Anganwadi centers also, adolescent girls are given meetings, and they are given information about this menstrual hygiene. So basically, these are the information that is, these are the things that are already available. Our duty is to bring together the pieces we can improve their youth healthcare. So we can definitely enhance the provider capacity. We can incorporate health promotion, disease prevention, and youth development. We can coordinate with all these services, and we can engage more and more young people. And we have to ensure that these vulnerable population gets the services, and we have to ensure that that confidentiality and the access to the care is available to this young population. So with these words, and I end my talk, and I welcome all the questions.
Thank you, Dr. Meenakshi, for your crisp and clear summation of the clinical aspects of youth-friendly services. And I think we have a lot of questions now, and we are already short on time. So we'll move on to the panel discussion. So I would like to invite Dr. Meenakshi Rohila as chairperson for the panel discussion. Dr. Meenakshi?
Yeah, I'm there.
Yeah, and Dr. Bimla Upadhyay as the co-chair for the panel discussion. She is a consultant reproductive health, UNFPA, New Delhi. Dr. Bimla?
Nina, I'm also here.
Dr. Nina, please also invite Dr. Shobha, because since she is also there, so we are lucky that she's been here throughout, and think her inputs will also be valuable in the.
I couldn't tear myself apart, because it's such an
interesting
perspective. No, also these matters are are very precious, because clinical subjects we always come across, but this is something partially public health and therefore very interesting. So we do have Rajal with us, with a very vast experience in adolescent healthcare in her region of Gujarat, and Dr. Pratima, who was instrumental in setting up adolescent healthcare, integrated services in the region of Delhi. So you can take forward their, and get their inputs. Yes, please. Yes.
So over to you, Dr. Meenakshi. Dr. Shobha, welcome to the panel discussion. And I would like to invite Dr. Kirti also, Dr. Kirti Iyengar, for the panel discussion.
Yeah. Kirti has to put on her video. Yeah, there she is. Yes.
I welcome all of you. I think we would like to have the questions that has been put up by audience in the question answer session first. Then we will continue with the questions that has been
planned already, right?
Planned already.
Correct.
So starting with the first question, I think this is from Dr. Dinesh. This is, I think Dr. Pratima can take up this, that please share your expert opinion on challenges in digital monitoring and online services.
Dr. Dinesh, I really don't have much experience, but I have seen that first thing is that, whatever you don't, the adolescent or the youth has a, availability of not showing himself, keeping him anonymous throughout the talk. So that doesn't really tell you what the real problem is, because in adolescent, most of the time they don't come out with the problem openly, only with their expressions, and with the questioning only we come to know the real problem. Because they will say just they have having pain abdomen, and it may be, then we keep on asking that what is the, when the pain arises, what happened, then they come with the history of sexual contact.
Yeah.
So that is very, very important, that if you are not able to really
The
talk
fear
to
of
them, see
judgment.
their expressions clearly, you will not be able to reach up to the point. Then rapport building is not so good, in telecommunication. I have seen that if the client chooses not to speak anything, or not to respond to your questions, then rapport building is not made. And if there is no rapport building, the confidentiality, confidence in the provider is really lacking in the digital setup. And thirdly is that again, you don't really know the circumstances. If they are in front of you, you can by their looks and everything, you can really identify what sort of culture they are coming from, and what type of home environment. Otherwise, if you keep on asking them on questions, so that rapport building takes a lot of time, while on digitally we are not able to keep that much of lock. Secondly, we don't know that who else is watching, in the home.
Can I say something?
Yes.
Yeah.
Yeah, sure, ma'am.
Yeah, thank you, Pratima ma'am. That is a very valid point. Actually, adolescents do not open up to health service providers, especially doctors, especially gynecologists. They don't open up easily. So, what is, I think, important is to build more friendly platforms for their digital interaction. We have some projects in Foxy right now. One is which I have been trying for the past few months, which is called as Ask Tanu, and it has been floated by the industry partner Bayer, and we will soon make it official because we have taken it through the Foxy Central body. So platforms like this, wherein anonymous robotic friend is available on the app, and any questions for contraception and safe sex are answered by the robotic friend. And then whenever the question goes beyond what is priorly fed, then it gets directed to a consultant, to a clinical service. So we are trying for something which is very simple, which is very kind of approachable for the youth, and it is essentially a youth friendly chatbot service. We are trying for that. So as Dr. Pratima said, the clinical interaction can be quite complex as far as adolescents are concerned, and they are afraid about judgment. And evidence in adolescent sexuality has come up with two main facts, I must tell you. The first fact is that a non-parental adult who is not a professional, not necessarily a psychologist or psychiatrist or a gynecologist or a sexual medicine expert, somebody who is a friend but is an adult, and it is non-parental, that person can make a difference to an adolescent who is seeking sexual advice about sexual reproductive health and about other behavioral issues, including substance abuse. That is one thing which has come up. The second thing is that there is a very early sexual debut today. Today, there is a very early sexual debut in our communities, and even in the so-called conservative community. So one cannot actually judge that they come from a particular traditional family. They would not have indulged. Nothing is like that. There is sex bar in adolescence, and they do take up the advice of periodic abstinence very well, better than adults. That is the second. The third important point, I think, is the POXO Act, and that all our adolescents are completely unaware that sex before 18 years, even if it is consensual, is considered as a criminal act and is punishable, and it is a punishable offense. They are unaware about it. and I think we have to make them aware.
I just want to add one thing, Shobha, that
Yeah.
this platform, though you said that rapport building is poor, I also said the same thing. But the advantage is that you can put on messages and you can
Yeah,
put on
that's
role plays, and that
You
putting
need
on
more
role
of
plays,
that.
even if you don't know whom you are addressing, but so many adolescents get their answers to their problems. So that is a very positive point of this digital media, coming from an authentic source and credibility of which is assured. So these role plays and messages can really help.
Dr. Rajan has anything to say?
Ma'am, Dr. Dinesh has already suggested this, that many times youth may be more open digitally rather than in person. That is what the suggestion he's saying, and maybe many times may be more effective also, as Madam said.
Yes.
Because
Ma'am,
actually they live inside inside their phone. Actually, they live more in that world, virtual world, rather than in the real
Yes,
world.
exactly. That is why probably they may be more open digitally rather than in physical. So the another question also, ma'am, it is for Dr. Pratima. How can we strengthen this service of medical abortion?
Medical abortion.
Yes, ma'am. This is from Dr. Renu Bedi.
So, Dr. Minachi, Dr. Pratima, if you allow, may I intervene here?
Yeah, sure.
So, I would just like to say that medical abortion globally has been found to be far more accessible to women and far more accessible to be provided by providers compared to the surgical abortion.
Surgical.
Even if you look at the India data, and if we go outside the cities, about 70% to 90% of the doctors are concentrated in the cities, while in the rural areas, the availability of abortion, any kind of abortion, has not been in more than 2 to 3% of PHCs. So it is very, very limited, because as we know, most of the MTP trained providers are based in the cities. So in fact, I know of certain cities where in rural areas not a single MTP trained MTP certified facility was there, while in the urban areas there are like up to 30 to 100 facilities. And what happens is, when to provide a surgical abortion, you need to have all the facilities of doing the vacuum aspiration, whether electrical or manual. You should also have your anesthesia apparatus to have a facility, everything has to be there. And all the pain control, some people like to use anesthesia also. While for medical abortion, all you need is, it is just a few pills, and all you need is that the doctor should know how to assess the size of the uterus. So if the doctor knows that this is a 8-week size or 7-week size or less than 9-week size, they can easily give medical abortion. And therefore, even if a doctor who's MTP trained, we know that so many MTP trained MBBS doctors, they don't really know how to do a manual vacuum aspiration or electrical vacuum aspiration. But if they are MTP trained, they can give medical abortion pills easily, because as long as they know how to do a PV and how to know the size of the uterus, they can rivet. And even if they don't, even if somebody has got an ultrasound done which shows that the duration of the medical abortion, duration of the size of the uterus is less than 9 weeks, they can provide it. So actually, medical abortion has a lot of potential to improve the access. And in fact, globally, it has been used very widely. Women are shifting to medical abortion. In fact, studies in India have also shown that about 80% of all women are getting medical abortion. And so we should actually make it very widely available. There are lots of myths and misconceptions among even gynecologists that it's a very risky method, but the studies have shown that it's a very safe method.
Here I would like to add one thing, that even Government of India has planning. Previously we were saying that even for medical abortion, that person should be registered and must have had a training, either 6 months house job, or so that has also been liberated, little bit modified, because only 10 days training is good enough. That is which will provide you that you can assess the size properly, and you can rule out ectopic pregnancy. And the most important is that that one has to follow the quality, that referral linkages have to be there. So training is very important, even for any provider anywhere, and this training now we can provide even on even on the digital platform also. The training can be provided, but besides that, definitely they have to assess the uterine size, which is very, very important, because you cannot give it to a 16 weeks the medical abortion, and you cannot give a medical abortion when you are suspecting ectopic. So those trainings are 10 days training. I think it's a must. But besides that training and proper linkages, I think medical abortion, strengthening the medical abortion services will definitely improve the safe abortion services.
I just want to add one point. Yes, we need to strengthen the services, but at the same time, the community or the people must be educated that these tablets are not to be taken on their own. And at the same time, the pharmacist also, they should not sell it. Although there is a law that they cannot prescribe without, dispense without the prescription, but then we get at least 2 or 3 patients in a week with, very low HB, and then giddiness and low, tachycardia, and we need to give 3 or 4 transfusions. So this is also a very at the same time we promote medical abortion, but then the women should not just take it like that. Very lightly. Taking it. Right.
Yeah, very, very correct, Rajal. You have really driven home the point that provider eligibility criteria need to be highly, highly stringent for MMA. Pratima Madam has correctly told that there is an increase in the provider base. Lately there has to be an increase in provider base. Even Kirti agrees to that. There has to be an increase. There is no doubt about it. But at the same time, as Rajal is telling, the eligibility criteria of the provider has to be stringent, and training has to be in order, and it has to be a registered medical practitioner who fulfills the criteria under the MTP Act. That conveys that it cannot be obtained over the counter. And Rajal is very right, 2 or 3 cases per month she is telling, but I have been given feedback that women have gone into hemorrhagic shock because they took the tablet from the pharmacist. And I have come across one feedback from one of my colleagues that a woman died. And these are happening in the times of pandemic because women want easy solutions. So they go to the closest one, they take it because unintended pregnancies have also gone up. They are quite desperate and they take it, and it can well happen to an adolescent girl, the group which we are discussing right now. And a very young life can be compromised or lost. So therefore, very correct message, medical method of abortion has to be popularized, but with all the caution, all the protection of health for the girl. Yeah.
Very rightly said, madam. I think that the next question is also Dr. Dinesh Kumar, and this is about the problem specifically of SRA services in married versus unmarried he has asked for. So I would like to answer this question that definitely the problems of married versus unmarried youth is challenging. Basically, first of all, we have to see the age of the youth, which age she is coming into. If definitely she is more than 18 and she is married or unmarried, then she has a right to take a consent, and she has a right to have a good information counseling about all the things that she wants to know. If she's more than 18, she has a right to know about the contraception counseling, abortion services available, any other services about the health education available. If she is less than 18, definitely we have some laws and policies that restrict her to have all services. So in that case, we have to see that if she wants to have some information only, that she has a legal guardian with us. And if she wants to know about the sexual education, she can be given, but definitely in the presence of a legal guardian only. If she wants to have information about contraception services available and any sexual and reproductive health services available, we need to counsel her. We need to tell her that she's, by law, she's not entitled to have the services available as of now. But definitely information can be given to her in the presence of a legal
information can be given. Information.
Yeah,
POXO Act doesn't say that information cannot be given. POXO Act says that if an act happens, then it is illegal. That is what POXO. So as gynecologists, we cannot prescribe contraception knowing fully that contraception can be used only in the context of an act. So that is the reason why we get implicated if we prescribe contraception before 18 years. So we can give knowledge about safe sex, about preventing, and telling them about POXO Act, and telling them the need to delay their debut for 18 years and above.
I think we do not have any more question in the chats.
I think I asked one. I think.
Yeah, madam, I have just read the question.
My question is to Sarita.
So
No,
really, Dr.
yes,
Shubha,
ma'am.
it's a really a wonderful experience on my part. I'm working on a medical college, and the three medical college I worked for last around 10 years. And being an HIV committee chairperson in from 2008 onwards, I worked hard on the HIV. So in my personal experience, I should suggest that if you have a motive to do something, you can really do it. So in my experience, I was not into the HIV committee. I never tried for having some integration like this in my own institute. But was when I was into it, like in my first test place of the medical college at Bilaspur, we had a good integration. The Department of Obstetrics and Gynae, the BCTC was started. The Dermatology department, they started the STI clinic, and there was a good linkage of the ART center with the district ART center. In this way, we were able to provide the good services to any women who is just coming to the walk-in in the OPD of the gynec department. She was being fully provided with all this. And the same is here with the tertiary care center in the Medical College Raipur and also in the All India Institute of Medical Sciences Raipur. So we are having an integrated service amongst this, but unfortunately, if you go and look at the primary healthcare center and the community healthcare center and even the some of the district center, this integration is still an incomplete integration. And the state implementation of these services in Chhattisgarh areas still has to be looked for to have a more better services, and that will be a definitely help. But
I just wanted to know whoever is providing integration, whether it is Rajal in Ahmedabad or Safdarjung Hospital, Dr. Pratima, or AIMS in Raipur, or in PGIMER, that do you have any infrastructural modification? Do you have a separate room? Do you have separate counselors?
not yet, but
Yeah.
coming to that, in the state government has just given us a proposal to start an STI clinic in integrated center for all these services. So maybe in the next 6 months or year, we will at least in AIMS Raipur will have this integrated center with us.
As you said, if there is a will, there will be a way.
Yeah,
And,
that's what.
yeah. And if to the will of the doctors, the political will is added, then I think it will come to pass. What do
Yeah.
you say? Yeah, Rajal has something to say. Yeah. No, you are muted, Rajal.
Not exactly for the clinical thing, but we tried to do, I mean, we have been doing integration for the UG students regarding the adolescent health. So, like the 5 departments: OBGYN, pediatrics, PSM, skin, and psychiatry. So, we have devised a small module, and then we
Wow,
took
wonderful.
session for the UG students,
Hmm.
and then later on we switch over to the PGs also. Very small things, but at least they should know, because UGs, when we always tell them that once you become medical officer, you should know that what is adolescent health. At least they should know what is adolescent health. So we started doing that for
That's
2 years
wonderful,
back.
isn't it?
So
Yeah.
this is the one thing that we have started doing
Acha hai
for
na?
PGs
Pratima ma'am,
and
that is
PGs.
really
Yeah,
nice.
yeah. Actually, I wanted to say something same. We started the clinic with psychiatrist, pediatrician, medicine person, and gynecologist. 4 of us started the clinic, and we used to call the skin specialist and dental person, occasion on 1 or 2 days of clinic. But I have seen, the thing is, it's very rewarding, but the provider has to be really motivated. I see the young generation which is coming, they're just not interested in adolescent health, because they see that the reward which they are getting is not
Nothing is
measurable. It is not measurable,
not a quantitative.
So then and the reward is very prolonged. You can get the rewards after 10 years or 15 years.
Yes,
Now
correct. Long term.
today I get a client whom I have seen in adolescent. She's becoming, she's 20 now, and she rings me up from Bangalore. Ma'am, I had this. Ma'am, I had this. What to do? So that sort of a repo comes only after, some years, So that thing is not there in the youngsters. So my adolescent clinic almost, stopped, because the people were not, the juniors were not interested to continue it. And I cannot continue it forever.
Yeah, I just want to add on to Dr. Pratima, my own experience. We started our adolescent clinic in AIMS also like around 2 years ago. But initial, maybe like in the routine hours, we can get the routine patient who are coming, the adolescent, and seeing them. but the voluntary coming for the counseling and all is nil. And we've also stopped the adolescent clinic. But my further experience, when we go for the school health education program,
Yes.
for the general awareness, like we had in a PCOS awareness program, and when we go, and then when we discuss about this reproductive health, and you can get the questions, a lot of questions related to their reproductive health, and then it's very effective. So rather than having adolescent clinic, we can have the school setups where these clinics can be there, and the gynecologist or the person can go and give something like in a month a visit. That may be a more helpful. That is my own experience.
That's what I said, that these clinics should be integrated with outreach activities. Even when we used to
Yes.
go to schools and community, then clientage used to increase in these clinics. So suddenly there is a surge, and then again, if you stop going to the schools or outreach activities, it will come down. So it is basically creating, marketing these services, which is very, very poor from the, at least from the, busy gynecologist. It becomes a little difficult. So
So can
I think online services will
Yeah.
definitely help in this.
Madhu,
related to
Madhu,
this,
Madhu.
I think, yeah. So I think community medicine department has a role to play here. They can actually go to schools. So this is what we are doing in PGI. So in our health centers, we have about 11 health posts. So we are actually providing these services by visiting to the school. So there is set pattern wherein our residents go frequently to these schools and provide these services, and we get very good response, as Dr. Sarita is
that's
mentioning.
wonderful.
I just want to add, definitely the tele services in this aspect may be of great help,
Yes.
because they just don't come to visit, and they are very busy to visit to the clinic. Even they have the inhibitions to attending this program, the schools. So if you start with the tele adolescent friendly clinic, that may be an effective program, I feel.
Trying to do that. Yes. That will be wonderful actually, to digitize our programs so that they can access and they can interact. Yeah. It's a good
Ma'am,
beginning.
very, very right, ma'am. Sorry to interrupt you, ma'am. Please continue.
Yeah, that is what I was trying to say, that digitization seems to be everybody's consensus on that we need to take this forward. And I think if Rajal, I think you'll agree with me that as specialist we cannot say that hum kar sakte hain. I think we have to integrate with other specialities, and we have to create a platform where we can come together so to give sustainable services of good quality. Because you see what a senior gynecologist like Dr. Pratima has to say. She could not sustain her services because she was not, she was not supported enough. So we have to create that atmosphere of mutual support and take it forward. What do you say, Rajat? Do you also?
Yes, absolutely. And at the same time, in a government setup or in a municipal corporation hospital, there are so many programs that are, going on. This
But are they working? Are Sneha clinics and all working, Rajat?
No, no, not at our place. It's not working. I tried to start one, but then I got transferred to the other hospital, and then
Is it only the pandemic or otherwise also? Because I do not find good feedback from Sneha clinics. So I'm just asking you. Yeah.
No, at our place we just tried to establish one. We tried to made a team of all doctors, and then we had the case papers and OPD.
That's what from public sector we must get inputs whether government schemes are working or no, because there is a lot of funding.
Yeah, government schemes or other schemes are working always,
but not this.
Even for the adolescent, there are all CHC and etc. They are having their the adolescent clinics.
Ma'am, sorry to
Just
interrupt.
wanted to come in here, Dr. Rajal. I have this experience. Sorry, I just wanted to add a point. Government schemes in some states are really working. In West Bengal, there are Anvesha clinics which are very good, and they are adolescent clinics, and they are running very well. Very high uptake of services, and good counselors are also there. So I think this is a state variations, and
then Vimla, this is a state government led project, Anvesha?
Yes, Anvesha is like RKSK clinics. They are like branded as Anvesha clinics over there. So they are running very well in West Bengal.
I just want to add one thing here again, bigger cities like Delhi, Bombay, Bangalore, Calcutta, these cities are, more into, providing clinical services. They are not focusing on these, but it is the smaller cities and the smaller PHCs which they get a person and their monitoring is also being done. So they do better in these things.
Maybe you're right. Yes.
I think we can.
And even the CHCs are also working. They are having an adolescent day also. Adolescent, they do come. So as Madam Pratima Madam has rightly said, that smaller centers and CHCs are having their, specified adolescent clinics, and they are working well. Same with the Gujarat also, and some of the medical colleges are also having started it and then working partially for this programs.
Yeah. Okay.
So sorry to interrupt, ma'am.
Yeah.
Sorry to interrupt, ma'am. I think Dr. Kirti wants to say something. Dr. Kirti has something to say. Dr. Kirti, ma'am.
So, can you hear me, Dr. Neela?
Yeah, we can hear.
Yeah. So on the this whole youth-friendly services, I just wanted to add that UNFPA is having an intervention. See, there are two approaches that are promoted by everyone. One is that you have these verticalized clinics, which are called adolescent-friendly health clinics, which are there in India. There are around 8,000 of all those clinics. Many of them have counselors, some don't have counselors. And the other approach is that every doctor and nurse is more youth-friendly. So because most of the people will not be able to go to an AFHC, and most of the people will have to go to an ordinary doctor or nurse, even if it's a 18-year-old married girl or a 20-year unmarried girl, they will have to go to an ordinary PHC doctor or a nurse or whoever else. And therefore, the need of the hour is to make everybody more youth-friendly, and that's the reason we have this intervention with PGI, where we are trying to conduct the trainings of the medical college teachers, and we also have some interventions in our states, UNFPA states, where we have done the trainings of the people, some of the ordinary doctors and nurses on youth friendliness, the basic concepts of non-judgmental attitude, positive attitude, maintaining privacy, confidentiality, etc. And I just wanted to have very brief. I wanted to mention about the self-care intervention, which was discussed in the first session, that WHO has come out with new guidelines on self-care interventions. It has just come out of these guidelines 1 year ago, and they taught of many self-care interventions. So Triranjit, I'll just take 1 minute to show the guidelines, if you allow me.
Sure, ma'am. Yes, ma'am, sure, go ahead.
Yeah. Okay. So I'll just take a minute. So these are the guidelines that WHO brought out about.
Share the screen, right? You must share the screen.
Meanwhile, I just want to add that at Gujarat, after having that training from SIDA, we had trained the teams of CHC, like the doctor, the nurses, then the class 3, class 4, even servants were also part of that team. So they are also taught about the confidentiality and privacy and all were like taught in the English and in Gujarati, so that their understanding is.
That is very important. Yeah. That is to keep a language which is friendly for the.
So we did that. Even that modules were translated also.
Because English may not be comfortable for a vast majority of our youth who come from the remote corners. So they need the regional language comfort.
Had done the translation also for all those modules of RKSK, and before priorly that was another one was there also.
AFHC.
So I and Dina did so many trainings, madam.
That's wonderful. That's wonderful. That is what has Kirti logged out to join in again?
Ma'am, she had some interruption, I think, some network issues. So
till then, I think we can put up some questions to other panelists also.
Yeah,
I think we can.
You have some planned questions, no? You can take them.
Yeah, Dr. Ritu is not with us, I think so. So I think till the Dr. Kirti is trying to show her slides, I think we can put up a question to Dr. Sarita. One of the part I think she has already answered. How is the private sector providing integrated SRH and HIV services? Dr. Sarita, please.
Yeah. I'm sorry, I could not listen to the question.
How is the private or public sector providing integrated SRH and HIV services? Or ma'am, any innovative approaches you suggest to improve delivery of integrated HIV and STI services? I think partially you have already answered this.
Yeah, basically the integration with the public-private partnership, as we are going in the other all sectors also in the family planning and the maternal and child health care, developing like adopting the private sectors also, and for the emergency medical obstetric care, the private doctors are being sent to the community health this first referral units where they can perform the cesarean section and they can be called upon for the family planning services. It's like that when I talk about the SRH and HIV services, some of the, it's like there are certain NGOs who are in Maharashtra stagnant in private sectors to provide the HIV services. And then they can be, these private centers who are ready to take care of the HIV positive care being supported by the NGOs. They can be linked with any of these areas, and these are specifically working in the urban slums where because of the like most of the centers we are being governed may not be available on the periphery. On such cases, the private public private partnership is a great help. I'm just forgetting the name of that NGO is working in the Maharashtra and giving a great work in the field of linking the services and the SRH and the HIV services.
Okay. Maharashtra, no?
Very, very right, ma'am. I think Dr. Kirti is ready with the slides, Kiran.
No, I think
No,
Dr.
ma'am, I
Kirti
think
has
there is
logged
some
out.
issue, some issue
So
with
we have received a message. I
Meenakshi,
think,
can I?
Is she connected? Audio?
No, ma'am. She suggests to go ahead and I
Okay.
think wrap up. Yeah.
Okay. I think we can. I think we can hand over to Dr. Bimla. She can continue with the Dr. Pratima and Dr. Rajan.
So, Dr. Meenakshi, we are also
Overshooting time, ma'am. Yeah. We need to actually
I think almost all we have discussed already.
Most of the things are discussed. Just a last question to I am putting to Dr. Rajal. That we see that SRH problems are associated with significant psychological issues. As clinician, we normally just treat the symptoms and fail to address the associated psychological problems. What is your opinion on that, and how can we train our residents to recognize symptoms of mental trauma and be more empathetic during counseling adolescents and youth? So this is last question I think we can take up. And
residents, the integration I have already talked that we can go ahead with that also, and keeping the psychiatry departments, so 5 departments: PSM, pediatrics, OBGYN, dermatology, and psychiatry. So we can emphasize, because I think the second number is the depression and the mental disorders for the adolescent, deaths and the problems. So we need to teach them and tell them about the problems. And secondly, adolescents will be more comfortable with residents also, because once we are talking in terms of peer educators, so I mean, they are also young adults. They are in their 25, 26-year-old or the 23-year-old residents. So I think we can make a team of them and give them, instead of listening to us, they will listen to them better. That is my opinion, that the peer educator team can we make from our resident doctors team. Madam Pratima, madam.
Ma'am, you are muted.
Madam, you are muted. Yeah.
Actually, Rajat, I am really disappointed at the response of the residents. You know, I started a mandatory training for my interns. You know, I said when the interns will do, then we will continue with all the years. I started that training every 3 months that interns were coming to us. So we were giving a training. We were not letting them go, I mean, giving a relieving to them unless they have done that training. And we used to arrange that training. So initially that training was for 1 day. Initially that was for 3 days. That was reduced to 1 day because there was no time. Then in 1 day also the interns were coming only for having, you know, pizza and all, because we were providing them lunch. So they were coming only for that.
What happens with interns, because they are preparing for their NEET exam.
Agreed.
So they are
But
not
I did the same
interested.
thing. I did the same thing with my residents also. But the residents also, they change so fast, and nobody is ready to go to the clinic. Nobody is ready to. They will say yes, they will do very well in the training, but after the training is over, everything is over. So that's the basic thing. So I think the best way is now the telemedicine, do role plays, just show them the role plays, and take their exam, take their some feedback from them in the question answer form or any form which they are which has to be mandatory. Otherwise they just don't do anything.
No, what I think is we need to mix both the things. Like, there are few residents who are, see, not every gynecologist is interested in adolescent health. There are few. So we need to identify, at least like each year, there are 4 residents in my unit. So at least 4 out of 1 would be there who we can, concentrate. So at least 25% positive result we can get.
Just wanted to say that any hospital where there is a good input of youth footfalls should have an adolescent clinic, even in the private sector. So while we were discussing about government facilities, I think private sector also should match up. And that's what the first question I had asked Sarita, that only whether there is any infrastructural modification to cater to their services. So it's important to have youth-friendly services identified as a clinic, a special hour for them, or at least a special digital time that from this time to this time we are available online for you to consult, etc. So that may become necessary. I think Dr. Vimla was wanting to ask what are the clinical signs to say that an adolescent is under emotional or mental stress. And clinical actually indicators will be there when there is a falling grade in exams suddenly, when there is missing their exercise schedule, when there are telltale scars on the wrists and other parts of the body, when there are injection puncture marks on their arms suggesting drug abuse, when they are incoherent in speech, and the parents report that the sleep times are very, very variable, when there is a sudden increase in pocket money expenditure. That actually sudden increase in spending indicates that there might be exchange for favors of drug, etc. So some telltale signs will come up in the course of clinical examination also, when there is a loss of weight or gain of weight, etc. Dietary patterns are very abnormal, and stress levels like always, like this, always kind of repeatedly doing something like touching their hair, or repeatedly scratching, or repeatedly breaking knuckles. They are all telltale signs of better judgment can be made by psychiatrists. So Rajal is very, very correct that we need to have a psychologist or a psychiatrist in the team when we are managing with adolescents. It goes a long way. That was the answer to your question. And I wanted to just tell you the FOXY intervention for SRH. I'll be speaking more about it on 22nd. But we have planned a FOXY eye care clinic in all private facilities. Some people are interested. They are taking it up. It is a dedicated cubicle on the floor of the OPD where all women and teens are seen, on the same floor with dedicated counselors. So infrastructural modification and human resources may have to be modified to give appropriate SRH service. That is the message I needed to give from FOXY.
Thank you very much, ma'am, all of you. Ma'am, I would like to share here that I am in the process of making a mobile application for youth services. So this will be based not for the information only. This will be for the treatment-based app. I mean, a young girl can log in onto this. This is for girls only. A girl can log in into this and can write down her complaints. In the drop-down menu, she can select all her complaints, and finally, she will end up with some summary of her case. And finally, a doctor, or she will call the doctor, and we will have a personal interaction probably will be there, and she may be more friendly and maybe develop more rapport with the doctor.
Yeah.
And I'm in the process of making this with the help of Department of Science and Technology, and it has been sponsored.
Okay.
Thank you, ma'am.
Actually, it should be a good intervention. It will be really good.
All the very best, Meenakshi, for you.
Thank you, ma'am. Thank you.
All the very best.
Very
We
much.
look forward to that. And Dr. Nina, I think you can.
And Shobha, I think if you we have been having meeting, which I was talking about the project with the USAID and with the Shops Plus.
Yes.
So that also we will be having in hotline also in that. And
yes, there is a hotline in that.
And there will be, virtual consultations and all those things.
And as I told you, ma'am, but there is another project called Ask Tanu, where which is a chatbot service exclusively for youth SRH. So maybe together we will be able to serve the 30 crore population of youth in this country because they have the maximum SRH needs.
Yes.
Yeah.
So,
Dr. Nina,
hand over to Dr. Nina, please.
Thank you, Dr. Meenakshi. Thank you, Dr. Shobha. Thank you, Dr. Rajat. And thank you, Dr. Pratima. Now I would like to invite Dr. Madhu to summarize the proceedings of this meeting and propose a vote of thanks for this.
Yeah, thank you so much. So I would just like to say here that today we had a really very good session, first of all by Dr. Pratima on adolescents. And especially it was shocking to see that how much adolescents we could not cover during COVID-19 pandemic. So that was really a very good information, ma'am. And overall, you covered almost all the aspects. And there's a lot of we have a lot of goals to complete actually, and we have gone really far behind because of this COVID-19. And then a session by Dr. Ritu Joshi on emergency contraceptives, and there are three more methods she has told, and she actually emphasized that this is safe and it can be used, but obviously it should not be a routine contraceptive method, but can be used safely. And in COVID-19, this should have been a good way to prevent unwanted pregnancy. Then we had a session by Dr. Sarita Agarwal, a very well presented session on integrated SRH and HIV. So which the main focus was that we have to ensure linkages between various centers and various facilities to provide comprehensive sexual reproductive health and HIV services. Then we have session from Dr. Meenakshi Rohila on the clinical aspects of adolescents, especially sexual and reproductive health related problems. And we have discussed a lot about those during the panel discussion as well. So, and we could have a lot of interesting discussion, and even I could not stop in between. It was so very interesting to listen to all of you. And I'm very thankful to Foxy, Dr. Shobha Guri, Dr. Alpesh, who's the president, and your team, Dr. Pratima Mittal, Dr. Rajal Thakur, Dr. Sarita Agarwal. So thank you so much for making it so successful. And Dr. Meenakshi Rohila, you had been a pillar of strength for us for this project, especially because we actually rely on you. And so I'm really thankful. And also UNFPA, because it was their idea to collaborate like that. Dr. Kirti Iyengar, Dr. Bimla Upadhyay, thank you for all your ideas and support. And my team, Dr. Nina Singla and Kiranjeet and Sham Joshi for putting it all together. So with this, I would like to thank all of you and looking forward to meet you again on the 22nd December for the second CME. Thank you.
Thank you very much, ma'am.
Thank you, Dr. Madhu.
Thank you very much, everybody.
Thank you. Thanks, all of you. Thank you. Pratima ma'am, bye. Rajal.
Bye.
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 Meena, Madhu.
Bye.
Kiranjeet, thank you very much.
Thank you, ma'am.
Thank you.